Welcome to the first of several lectures about pediatric physical assessment. So how does physical assessment of a child differ from that of an adult? Well, you're going to be challenged quite a bit because you are dealing with a wide range of ages. These children will not cooperate the way you are used to with adults, although I have had adults who have been uncooperative as well. But as we discuss the lecture about physical assessment, I'm going to point out several differences. I've posted one page that has the variety of links that you're going to see in the lectures for week 1, and click on them and watch each one. The one on this slide, you get to see a 9-month-old having a physical assessment. He's really cute, and he's actually quite cooperative. So speaking of cooperation, depending on the age, depending on how tired the child is, depending what the child is coming in for, is the child sick or is the child in for a well visit, will depend on how cooperative they will be with your assessment. Most of the time, the child is going to look at you and be fearful. They do not trust you, especially children who have been admitted and we have poked and prodded them every day, in and out, for perhaps weeks. These child will recognize you with your stethoscope, with your white, and be fearful, because after all, anybody who has looked like you has done something that they didn't like. The children are going to cry, but we have to do the assessment anyway. And so what you need to work on is your approach to the child. Don't look directly at them immediately. Look at the parent. Look at their toy. Engage them in play. You can actually do quite a bit of your assessment just while playing with them at the bedside. If they are not crying and they are sleeping, you need to be in what I call stealth mode. You know, the stealth bomber. You don't know it was there until it's already flown past you. Well, that's what you're going to do. You want to sneak in and get the respiratory rate and the heart rate, perhaps even the blood pressure, without disturbing the child. Then you can do the more invasive, which would be taking the temperature and the blood pressure. You're going to have to focus on communication techniques because you cannot talk to a toddler the way you would an adult or an adolescent or late adolescent. And there are going to be some adolescents who will be less than cooperative just because they can be. A very important assessment that we do in pediatrics is height, weight, head circumference. We do this at each visit. For well child exams, this is done by the nurse before the physician or nurse practitioner ever sees the child. When we admit a child, we at least do the height and the weight. Some institutions will measure the head, some won't. We need to keep the head circumference measurements until age 2 because the brain is growing, and we want to make sure that they're following along on their graph, which is coming up next. We record the weight in kilos and the length in centimeters, and then convert it to pounds and inches because the parents don't know kilos and cms. And then we will plot them on a growth chart. We will be practicing this in Skills Lab. So this slide shows the variety of growth charts that are available from the CDC. And I've given you a link on the paper that I told you that I have a variety of links. So you can go to them because you're going to need them for your care plan. So this one is for a boy between the ages of birth through 36 months. Now on this side, we can plot the length and the weight on the same piece of paper. If we were to flip this over, we would actually be able to plot the length against the weight. And we use all of these to see how well is this child growing. Now you're going to see all these blue lines that are going across and curved. Well, those represent percentiles. 5th, 10th, 25th, 50th, 75th, 90th, 95th, and the 100 isn't even there. As long as a child stays on their own growth line, they're fine. It doesn't matter if they're in the 5th percentile. Remember, apples fall under the apple tree. So if you have a parent who is 4'11" and the other parent is 5'2", you don't expect a giant child. But we have to watch this, and when we talk about failure to thrive, this is going to come into play again.